So if I could introduce the second speaker, and I think it's just going to be Lisa. With great pleasure that I introduce our third speaker, Barida Poi, an obstetric and gynaecology specialist trainee and one of the East of England Global Health Fellows in 2023. For those of you who don't know, the Global Health Fellowship Programme provides trainees the opportunity to enhance their training and develop a holistic view of the importance of global health by working within an established partnership with low and middle income countries. It's something that's quite unique about the East of England, and that Evelyn and Wilf and Rowan and others have really sort of spearheaded. It's an absolute fantastic initiative. So Barida has a keen interest in global health and a passion for education and improving outcomes in women's health. And for her fellowship, she was involved in the Kakamega Cambridge Antimicrobial Stewardship Partnership. Sorry, long words. The partnership is laying the foundation to reduce maternal mortality in the densely populated region of Western Kenya by improving infection prevention and control, tackling antimicrobial resistance and improving stewardship practices, arguably things that we also reflect on here day to day. As part of her fellowship, she co-created and co-delivered a training in management of sepsis and infection control at Kakamega County Hospital and helped to disseminate new learning and skills to referring hospitals across the county. Welcome.
Hello, good evening. So in terms of my presentation, I just thought I'd give a little bit of background to myself and how I ended up getting to this point, the aims within my Global Health Fellowship, the project itself in Kakamega, the ability and the opportunity I had to start a Global Health Masters, my future plans and my reflections of the fellowship. So there's a picture of me. I am an East of England Obs and Gynae trainee since about August 2019. I have always very much been passionate about improving maternity outcomes given my ethnicity and my background. So I'm originally from Nigeria, and I know that it has a population of over 206 million people, and yet the lifetime risk of a woman dying in childbirth, pregnancy or postpartum or post-abortion was 1 in 22. So if we use a basis of comparison for that, within the UK, the maternal mortality ratio is 9 in 100,000. In Nigeria, it's actually 1,000 in 100,000. So for me, that was significant, and it was something that I always knew I wanted to be involved with in terms of making a meaningful impact and change to adjust this. But I had no idea once I completed med school how to go about this from a global health perspective. We cover global health within our training matrix, but it's never quite applicable to the work that we do on the ground. And I was never quite sure how I'd be able to branch into that until thankfully I received an email advertising the Global Health Fellowship, applied, and someone felt it was in their best interest to give me a shot. So within that, I've always been passionate about implementing that change through medical education. So my aims within my fellowship was to engage in the international project within the established health partnership, to pursue a postgraduate qualification in global health, and to attend and participate in conferences and courses to develop my understanding, as well as my leadership and management skills. So within the Kakamega Maternity Project, there was already a fantastic partnership with the Commonwealth Partnerships for Antimicrobial Stewardship, which is CWPANS, within the Kakamega County Teaching and Referral Hospital in regards to antimicrobial stewardship that had already laid down a fantastic foundation. However, when the team had visited from Kakamega to Cambridge University Hospital, they'd highlighted that there were concerns in regards to the management of maternal sepsis. They were happy in terms of the impact and the research that had already been conducted with the management of postpartum hemorrhage and the management of preeclampsia, but there was a gap in terms of their knowledge basis and implementation of how to manage sepsis. So in May 2022, they then made funding available to then have projects to then address this. So via Zoom, we were able to communicate and liaise and collaborate in terms of the issues that they were facing and ways in which we could then help and collaborate to address them. So our aims were to support and provide training in infection prevention control, antimicrobial resistance and antimicrobial stewardship, and the assessment and management of sepsis within maternity. So a bit of background to the hospital themselves. It's a 650-bed level 5 hospital, so that's a hospital that receives referrals from smaller hospitals in the area for complex cases. They have over 6,000 deliveries per year, which is similar to the Rosie, I believe, but bearing in mind they cater for a population of just over 2 million. And going back to that comparison I mentioned before in terms of the maternal mortality ratio, given that in the UK it's 9 in 100,000, within Kakamega, or within Kenya specifically, is 316. So it was really important that we're able to address and tackle the reversible causes of this. So on the first day, in the pictures there, you can see myself and some members of the team. There's Catherine, one of the lead nurses, as well as Charlotte Patient, my supervisor. And we were discussing with Violet, the midwife, on the postnatal ward, in terms of the practice they had in place, the proformas they had in place to address sepsis, but where the gaps were, what they needed from us in order to address the issues that were raised. On the right-hand side there, that was the high dependency unit they created in order to monitor their most high-risk patients. And I believe there was a patient who had just come in, I think, day 20 post-cesarean section who had had an eclamptic fit. So we're just going through the documentation and how they were managing their early warning scores for patients who were at risk of deterioration. So what we decided and how we came to tackle these issues was to create a workshop, which is a combination of theory lectures and simulation training in infection prevention control, the assessment, the diagnosis and management of sepsis, as well as linking in the work that had already been done regarding antimicrobial stewardship. We also had health talks provided by some of the local lecturers in the hospital and Mercy, who I can see hiding in the back there, as well as some case presentations and post assessments. So it began with, like you mentioned, some of the lectures kind of going through the rationale for why we were tackling sepsis, the assessment of how you would assess a clinically deteriorating patient most likely due to sepsis, and therefore how you would then apply that to your patient in the clinical setting. So on the right-hand side, you can see Charlotte was managing the management starter station, and we were able to source out some simulation models to be able to practice and implement the learning from the theoretical lectures in terms of IV cannulation, giving fluids, antibiotics, etc. This continues with the health talks, and in the first picture on the top left-hand corner there, that was the infection prevention control. So that was in regards to sterilisation of instruments, how they were disposing of infective waste, and just keeping the area generally clean, as well as hand washing protocol. Down below you can see myself with Dr. Mutaka, one of the consultant obstetricians, and I was a very melodramatic mother of 11 who was very unwell and feeling unwell with signs of infection. So within this, we were able to give a simulation station to talk through how we would assess our patient, what investigations from the bedside we would do, and what triggers would then make you think of sepsis, using the modified early warning obstetric warning score. We were also able to develop some small business cards with the key salient points about the assessment and management of sepsis and what to do if you were concerned for sepsis. Because I think most of the clinicians and the medical students who attended were aware that sepsis is a critical condition and patients are unwell, but weren't quite sure about the steps to follow and in what timely manner to implement them. So ideally the idea was to take home these business cards to then be able to remember if they saw a patient who was at risk, how to then implement that management. So in terms of the impact and the outcomes, it was performed over a 3-day period, and we delivered the workshop to 77 delegates, and we were able to collect formal feedback to assess the appropriateness of training and the areas of improvement. Overall, it was very well received from medical staffing and students regarding the MEOWS chart specifically in terms of being able to identify the at-risk patients, as well as the simulation training, because it's one thing to be spoken to and have lectures, it's another thing to be able to implement that training on the same day. And the fantastic thing about it was that we could see improvements in the clinical settings as of day 3. So within the workshop, we also did bedside teaching to say, these are the elements we've learnt within the lectures. What can you see within the clinical setting that we can improve on in terms of infection prevention? How can we improve the settings? So by the time we performed that same exercise on day 3, we could see the delegates who had attended on day 1 had already implemented that in terms of waste management, in terms of using hand washing stations, in terms of how they were looking after patients. There were already tangible changes as soon as day 3, so it was fantastic. So in terms of outcomes to continue the learning, we identified sepsis champions to then continue the training in peripheral hospitals and units. We also had resources available to create a simulation suite within the county hospital for further training in obstetric emergencies in the simulation sort of fashion, such as PPH, preeclampsia, and to continue the sepsis management we were doing. We were going to then consider the development of a hybrid approach for simulation training and implementation of the guidelines, tying in back again with the antimicrobial stewardship, and creation of resources to affirm postnatal health messages and IPC. So within that, we were able to create sepsis boxes that had the key elements of what you would need to assess your patient at the bedside. So pulse oximeters, blood pressure monitors, thermometers, anything you would need for that initial assessment, so that if you were queried and you were concerned for sepsis, you grabbed the box, you assess your patient, you had everything you needed in one place. After that, or alongside that, I was very grateful to have been given the opportunity to have some partial funding towards pursuing a postgraduate qualification. So I chose to start a Global Health Masters with the Liverpool School of Tropical Medicine. I started that last year in September. What I loved about the course is that it was part-time and distance learning, so I could still continue to do that along with the work and the partnerships and my clinical work. And the aims of the Masters, as you can see on the presentation, were in line with the values I believe we see in CGHP, as well as the values that I wanted to learn a bit more about. So these are just a quick overview of the modules that I do, particularly boring for you, but for me was very exciting in terms of what I'd be able to delve into and the exercises and assessments associated with them. So, for example, in my first year doing the health promotion module, we were tasked with creating a health protection response and therefore assigned different roles within what you would have within your team of managing a crisis, and therefore an assessment and a management kind of protocol for that issue. So within our group, we were managing the COVID outbreak and the media response in regards to that. So I was allocated the role of communications lead. So I was responsible for critiquing current media and press coverage and the outbreak in terms of incorrect messages, and had to create a communication strategy of how to address the bias and how to address the issues faced in disseminating the evidence that was available and the information available, whilst kind of tackling healthcare inequalities, which was very challenging but also very rewarding in that process. I learned a few skills along the way with that. In terms of my future plans, as a result of the work we've been able to do in Kakamega, I was able to submit some abstracts for the Developing Excellence Medical Education Conference, which I will thankfully be presenting in December of this year, with the following abstract titles, as well as participating as part of a workshop with working within the global community, developing global health fellowships in the East of England. Also pending paperwork, I will plan to start as a CGHP volunteer from this year to as long as you guys will have me, really. So in terms of reflections from the experience, I cannot thank CGHP and HEE enough for the opportunity and the experience. It has changed my life in more ways than I can actually articulate. Knowing who I was 1 year ago to who I am now, I'm a completely different person in terms of how I approach things, how I plan things, the importance of global health to myself as well as my local community and the international community, and it has significantly impacted where I'm going in terms of career opportunities and options to consider how I can actually incorporate global health within my day-to-day practice and career aspirations, really. So once again, it has been an incredible opportunity and I am very grateful and thankful.